And without further ado, Research to Practice update on prostate cancer screening with Marc Bjurlin, DO, MSc, FACOS. And rather than read the bio, we're going to talk about the top 5 that we have for Dr. Bjurlin: the DO, MSc, FACOS, and an assistant professor of urology. He is director of clinical trials at the University of North Carolina, Chapel Hill. Dr. Bjurlin completed his residency at Cook County Hospital in Chicago and then a fellowship in urologic oncology at New York University. Prior to joining UNC, Dr. Bjurlin was assistant professor of urology and director of urologic oncology at NYU Langone Hospital in Brooklyn. And finally, his research interests include the molecular epidemiology of smoking and e-cigarette use-related bladder cancers. Dr. Bjurlin, welcome.
Thank you so much for the kind introduction. Very excited to be here today to talk about prostate cancer screening and some new kind of thought processes, how we can screen smarter for men at risk for prostate cancer.
Well, we are definitely looking forward to learning about that. What's one thing we should know about you personally outside of your professional bio?
Well, I am a transplant to North Carolina, came from New York City, and now my wife and I have 3 dogs and are super happy that we are members of the Chapel Hill community.
Great. It's a great place to be. And I was guessing your education was from the Midwest with that DO, because I think that's pretty much it in terms of where you can get a DO. Is that right?
It's becoming more common now. There's actually one at Campbell University here in North Carolina.
Okay.
More and more of us are doctors of osteopathic medicine.
Great. Great. Well, here's that first pull everywhere question. These ones we try to make pretty easy. Prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. True or false? And while we are waiting for those to come in, I will say that here's our first disclosure. I don't have to read it anymore, but I need to put it up there. Our ANCC disclosure. And let's see how folks are doing. So please take about 15, 20 seconds to think about this and then go ahead and put in your answer. Again, these are all anonymous. So it looks like we're leading in the true row there at about 85%. So prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. Dr. Bjurlin, how are they doing?
Pretty close to getting it all right. I would say that prostate cancer, as we will learn, is the most common malignancy in men and is the second leading cause of cancer death in men in the United States.
All right. Well, thanks to our audience for responding. And without further ado, I'll turn it over to you.
Wonderful. So again, just to briefly introduce myself, we'll be discussing today on the updates in prostate cancer screening. In terms of any disclosures, my disclosures are listed here. Of note, I am a clinical investigator on a drug that we treat men with high-risk prostate cancer, but none of these disclosures are relevant to today's presentation. So things that we're going to cover today is, first, we're going to spend a little bit of time really taking a look at the history in terms of the limitations of what's called prostate-specific antigen, PSA screening. It's the blood test we screen men for with prostate cancer. And we're going to spend the next few moments discussing strategies on ways that we can screen men for prostate cancer in a smarter method than currently what we are. And then some of those smarter ways of screening men will be incorporating a prostate MRI into a man's cancer risk to both assess their risk of having the disease and where the disease may be. And then we're going to talk a little bit on some new molecular markers that are endorsed by national guidelines. Some of them I have listed here. They are both blood markers that we can simply obtain from a intravenous blood draw. And then some of these are urinary markers where men can give us a urinary sample to understand their risk for prostate cancer. So to get this started, this is probably a slide that people have seen in the past, but you can see on the left-hand side of the screen that prostate cancer is the most common malignancy in men. In 2023, there's estimated to be just under 300,000 new cases of prostate cancer. And that's probably somewhere around every 1 to 8 or 9 men. So I'm not sure how many people are on this call, but not to be morbid, but if there's 4 people, behind me listening to this and 4 people ahead of me and listen to this, one of us, 8 or 9, will probably be diagnosed with prostate cancer sometime in our lifetime. And then you look at estimated deaths on the right side of the screen, that you can see prostate cancer is the most common, or the second most common cause of malignancy among men. But we should be aware that even though prostate cancer is very common, a large percentage of men do not die from prostate cancer. And because prostate cancer can be an aggressive disease, but often it can be a disease that is not aggressive. And that's much different from what you can see here, lung cancer, which being the second most common disease, but the estimated deaths from lung cancer is much higher than prostate cancer because that's a much more aggressive disease. And things we'll talk about today is how we can better risk stratify men in terms of, are they at risk for prostate cancer? Should they undergo a biopsy to detect prostate cancer? And then eventually, does that prostate cancer actually require treatment? Because there are many types of prostate cancer that can be observed without radical intervention. So if we want to look a little bit closer to home in terms of the state of North Carolina, in 2023, there were just over 10,000 anticipated new cases of prostate cancer among the men in our state. And at the same time, there's just over 1,200 deaths from prostate cancer. So definitely on the forefront of men's health care. We'll spend a little bit of time on this slide today going over the impact of policy changes on prostate cancer screening. And if we focus initially on this slide on the left, this is the incidence of prostate cancer. And this dotted red line here shows that in about 1989 was the year that we started screening men for prostate cancer with a PSA, prostatic specific antigen blood test. And you can see here that the number of cases of prostate cancer rose dramatically. And these were all men, living with prostate cancer in the community undiagnosed. So these men rapidly became diagnosed with prostate cancer when we adopted PSA as a screening tool. And you can see we caught up with the number of men who were undiagnosed. And then for several years, we were generally stable at the rate we were diagnosing men with prostate cancer. But you can see here in the late 2000s, this number started to dip, and then actually quite dramatically at about 2008. And that's as a result of some policy changes and some major governing bodies that suggested that we no longer screen men using PSA for prostate cancer. That came down until just before 2015. You can see this peak down here, at which time some policies were reversed, and this number is starting to climb up. And this may continue in perhaps the wrong direction unless we find a smarter way to screen men who are at risk for prostate cancer than what we have done in the past. If we shift gears a little bit now and look at this graph on the right side, you can see prostate cancer here highlighted in brown, and along with the adoption of PSA screening in about early 1990s, you can see there's been a dramatic drop in the mortality of prostate cancer related deaths from about just over 40 per 100,000 down to about 20. We've cut mortality rate by 50% in men using this tool. However, PSA screening itself doesn't account for all of these drops in mortality, but our best models out there do suggest somewhere between a third or 50% of that reduction in mortality has been a result of prostate cancer screening. And the only other malignancy that has had a steeper decrease in mortality than prostate cancer is that of lung cancer. And we know the reason for that is because of smoking cessation. So kind of with that in line, we really need to talk about that there exist racial disparities in prostate cancer diagnosis, screening, and mortality. This was a very well done study published in 2016 that looked at trends in white men and trends in Black men in terms of their prostate cancer mortality from the 1990s to the late 2000s. And if we want to look at some of this data in more detail, the white the white circles signify the change in mortality for white men, and the black circles highlight the change in mortality for Black men. And if we want to take that a little bit closer to home, you can see one of the cities they evaluate was here in North Carolina, Charlotte, and there was a 41% mortality reduction for white men and a 36% mortality reduction for Black men. So overall, Charlotte is moving in the right direction in terms of lessening the mortality rate of prostate cancer. Other cities perhaps did better. You can see that Minneapolis actually had a 72% mortality reduction in Black men over the last 20 years, but there's some cities that actually did worse. You can see here Miami, Florida actually had an increase in mortality both for white men and Black men. So ultimately, we need to realize that there's some national guidelines for screening that may or may not be adopted, as well as some local variation and disparities in terms of prostate cancer mortality. So the question becomes that if we manage to drop prostate cancer mortality by 50%, why, when this new study was released in 2023, coming out with cancer statistics, did we find that more men are being diagnosed with advanced prostate cancer than prior? And that is because we stopped screening men for prostate cancer as a result of some of those policy changes. You may have recalled this was from January of this year that it made all the national news sources that this was the only malignancy, prostate cancer, that actually rose, meaning that men were being diagnosed with more advanced disease and more metastatic disease, that disease outside of the prostate, because we're simply not screening for prostate cancer anymore. And when men would present, they would present with much more advanced disease. So that begs the question, why did this happen? Why are we going in the wrong direction in terms of trying to diagnose men with prostate cancer? And that may be partly because the United States Preventative Services Task Force came out with a recommendation in the 2010s that essentially said we should stop screening for prostate cancer. Do not use the prostatic-specific antigen blood test to screen men for prostate cancer, because essentially they thought we were diagnosing too many men with low-risk prostate cancer who then went on to radical treatment, which they didn't need, because low-risk prostate cancer essentially is not lethal and may never impact the man's longevity. So what did our primary care providers essentially hear that are at the front of prostate cancer screening? They saw this here that essentially says, do not use this test and don't screen for prostate cancer. And as a result, men didn't get checked for prostate cancer, and not until they had additional symptoms, back pain, kidney pain from disease that's blocking their bladder, did they actually get diagnosed with prostate cancer. So really, in our mind, we think this is perhaps a step backwards. Instead of stop screening, we should screen smarter and a different strategy than we have in the past. This is a somewhat famous diagram that was published in the New England Journal in a perspective piece several years ago. But essentially what it shows is a comparison of metastatic disease among individuals being screened for prostate cancer, and then metastatic disease among men being screened for prostate cancer. And you can see here that the method for screening for breast cancer has been mammography, and the rate of metastatic disease really hasn't changed in the last 35 years, meaning that even though we're screening women, we're not dropping the rate of metastatic disease. However, if you look at that compared to prostate cancer, When we screen men from prostate cancer, you can see a dramatic drop in the incidence of their metastatic disease, meaning we're catching this disease before it spreads outside of the prostate, where it can be watched closely, or these men can undergo treatment if they deem that they have a disease that requires treatment. So even though as a urologic field we were criticized for perhaps not screening smartly, really I think from this chart it shows that this PSA blood test may be one of the best screening biomarkers in the history of oncology, because you can see that enormous drop in metastatic disease. However, we've really adopted it in a poor type of screening strategy. So briefly to kind of summarize what we've discussed up till now, that in terms of prostate cancer screening using the PSA blood test, we poorly implemented that in the last 20 years. Essentially, we're over-screening elderly men who may not have a longevity to benefit from screening. We were under-screening young men, meaning those men that had the most amount of years to live were not getting the test, and those are the men that would most benefit from it. We did drive down mortality, death from prostate cancer by over 50% over these last 30 years, but that came at a cost, and those costs were the side effects of treatment. Some of the common treatment side effects we see with men with prostate cancer are urinary incontinence, and then erectile dysfunction, sexual dysfunction, and there's a large proportion of men that don't need those radical treatments with their attendant risks. But this was a criticism of this approach for screening. So really, was screen none the solution? And we don't think it was, even though that was instituted in some guidelines in the early 2010s, but rather we need to adopt an approach that we screen men smarter. And then historically, in terms of what value should we call abnormal for prostate cancer screening, there was this kind of ubiquitous adoption of a 4 level, meaning a PSA above 4 is abnormal, a PSA below 4 is normal. And really, this has kind of been shown that it was a terrible idea to try to use this universal screening level for all men, when we know different race have different impact on the amount of PSA that men may produce, and different aged men should be probably screened at different thresholds. So really, we had some work to do, and I think that future guidelines have now adopted a risk stratified approach in terms of screening men at risk for prostate cancer. So we'll pause here and just review our next poll question. PSA guidelines 4.0 focused on inadequate testing with the wrong population groups. And I'll give us just a couple more seconds to view that question, but I think our audience is spot on when they're saying 100% of people agree that really using that threshold was not the best strategy choice, and I think that we could really screen the right populations better using a different approach. So the National Comprehensive Cancer Network came out with new prostate cancer early detection and screening guidelines this year, and they really changed the way we think about who we should screen and how we should screen. And these are the algorithms that the National Comprehensive Cancer Network puts out. But I'm going to highlight a couple of things here. That if you are a man aged 45 to 75 years old, and you are average risk for prostate cancer, their recommendation is you should get a PSA test, and their threshold cutoff is 1. So your normal value should be less than 1. If you are a man in that age group and you get a PSA test and it's less than 1, you don't need to repeat this test for another 2 to 4 years. It's a different screening approach where we think it's more risk adapted. And then just to kind of look at the area underneath this, if you are at higher risk for having prostate cancer, meaning that you're a Black or African American man, you have some germline mutation that you may or may not actually know, but if you happen to have that germline mutation in your family and you're aware of it, or if you have a family member with prostate cancer, meaning a first-degree relative, brother, father, uncle, this puts you at higher risk for prostate cancer, then the threshold for screening slightly changes. The recommendation is you should still get a PSA blood test, but the cutoff is now less than 3. And if your value is less than 3 and you fall into this group, you should repeat this every 1 to 2 years. And we think that using this type of risk adapted approach better suits men who are at average risk to catch any disease that may be lethal. That would be the early detection evaluation you can see here. And that men who are at higher risk disease, we've also caught them earlier. We start screening at an earlier age, and we've identified those risk factors so we can detect any disease when it's still locally confined to the prostate and avoid those men presenting with metastatic disease. But this is really not the only change that the NCCN guidelines recommended for prostate cancer screening. They've also added in another step here, in that if you're a man with an abnormal prostate cancer screening blood test, our first step you can see here is we repeat the blood test, meaning you need really 2 abnormal blood tests to say, you know what, this is a gentleman that requires further evaluation. Just because you have one abnormal blood test does not mean you need to go straight to a prostate biopsy. In men with 2 abnormal prostate blood tests, the next kind of risk stratification test that the guidelines now recommend is that men should get a prostate MRI. MRI is just magnetic resonance imaging. It's a high-powered magnet. It gives us a very high-resolution image of men's prostate, and it allows us to kind of risk stratify them further, whether we think they have a disease that require a biopsy, or is this someone we can possibly watch? And you can see risk stratification next steps. If you get an MRI and you have a low suspicion of having cancer, you don't need a biopsy. We can continue to watch you closely to make sure that doesn't change. However, if you have some abnormal PSA blood tests and you get an MRI that's abnormal, these are the men that may benefit from a biopsy. The second addition that's been brought into the guideline for prostate cancer screening, you can see here, consider biomarkers that improve the specificity of prostate cancer screening. And the NCCN lists these 6 biomarkers as kind of additional tests that we can get men to help determine whether they may be at risk for having prostate cancer. So we'll spend a little bit of time going over those next, but just to summarize and lead to our next question, smarter prostate cancer risk assessment includes which of the following? A, an MRI and a biomarker, B, MRI and ultrasound, C, MRI, biomarker assessment and ultrasound, and D, PSA, MRI, biomarker assessment and ultrasound. I'll give us just a second to go over those in a little bit more detail. But I think what we've discussed and what we'll get into is all 4 of these tests really allow us to further risk stratify men at risk for prostate cancer. Both the PSA as the initial test, the MRI as an additional risk stratification test, one of the biomarkers, which we'll go over in more detail, and then actually when we do a biopsy, we do part of an ultrasound that gives us some more detail on men's risk for having prostate cancer. So one of the American Urological Association kind of policy statements really has now said, and I can read this, that when quality prostate imaging is obtained, there's really enough data that suggests that an MRI should be obtained in all men prior to their first biopsy, unless there's some reason they can't get it. For example, they have some metal in their hip that's not compatible with the MRI machine. Now, if we're going to consider biopsying men for prostate cancer, they should all get an MRI prior to their biopsy. And this is beneficial for several reasons. One, it allows us to really detect or to look at what's the likelihood there's actually going to be disease on biopsy. And then secondly, we can use that data to counsel men And hopefully in the low risk men, it gives an opportunity to avoid that biopsy. This is an example of a prostate MRI and the scoring system that we use to evaluate this MRI. In the middle of the picture here, you can see that this gray area in this circle is the prostate itself, and this dark kind of gray black area with the arrow is the prostate cancer that we can see on an MRI. When our radiologists interpret these MRIs, they give us a scoring system on a 5-point scale, and they say, you know what, we see an abnormality, and then they can tell us how likely that abnormality actually has clinically actionable cancer in it. And it's on this scale of 1 to 5. It's called a PI-RAD scale. And we know in men with PI-RADs 1 and 2, this is fairly low risk that they're going to have cancer. By definition, PI-RADs 1 scores are very low risk. PI-RADs 2 scores are low risk. And you can see here about 2% of men with this score of 1 will have prostate cancer, meaning 98% will not have any disease. So it'd be reasonable that someone could avoid a prostate biopsy if that was your score. PI-RADs 2 has a score of about 4%, meaning 4% of men with that score will have prostate cancer. And this continues to rise as this interpretation score goes up. If you have a PI-RAD score of 5, there's about 90% chance you will have prostate cancer in that abnormal area of MRI. And I highlight these 1 and 2 in red because that's kind of our stop sign, meaning that if you have a low risk MRI, even though your screening blood test may be elevated, we've done this additional risk assessment tool, and you can probably avoid a biopsy if you fall in this low risk category. In men with a higher risk category, these are the ones that may benefit from some type of prostate biopsy, given they have a higher likelihood of having disease. So we can see that the MRI risk stratification score can be used to counsel men. This was some individual institution data that shows that as this MRI suspicion score rises, the likelihood of having cancer rises. And this is both can be applicable to men who've never had a biopsy, as well as men who've actually had a biopsy for having an abnormal blood test. And then in some men, though that abnormal blood test continues to go up, that's not uncommon for men. They can have a screening prostate PSA. They undergo a biopsy. The biopsy doesn't show any disease, but their PSA continues to rise over time. And this same type of scoring system can be adopted and counsel men to see if they have risk in their subsequent years of life. This is the same kind of scale that we use for men with no prior prostate biopsy, and it looks at, is there actually disease that needs to be treated, meaning that there is a subset of men, if they have prostate cancer, that does not need to be treated, but there is a subset that would benefit from treatment. And you can see, based on the MRI alone, we can counsel men that say, you know what, if you have a region that's scored as 5, 80% chance you're going to have some type of disease that needs treatment. If you have a score of 2, there's just under 6% chance you may actually have a type of prostate cancer that would need to be treated. So very informative in order for us to discuss these findings with men, and then can help really give them several opportunities to have an off ramp to avoid a prostate biopsy. And we just essentially keep a close look at their PSA blood tests every several months or yearly, and then we can catch any disease if it was to be developed in the future. So we've adopted this type of strategy into these nomograms that we use in clinical practice. And just to briefly show you how these nomograms work, we take a prostate MRI score, like we talked about. It's on that scale of 5. You can imagine if a gentleman has a score of 5, their PSA density, which is their PSA value divided by their prostate volume, gives them a number. And then their age, we take those essentially 3 data points, find it on this scale. Essentially, we draw these lines up here and it gives us numbers. We add those numbers up. So this 5 goes up to this line. That's about a 35. Here's our score there. PSA density of 0.1. That gives us about 8 points here. And then the age, 65. That gives us about 2 points. Add those up. We get a total score of about 45 on this nomogram. We find 45 on this nomogram, and then we can say, you know what, based on these 45 points, you have about 87% chance that you'll actually have clinically actionable disease on your biopsy. And this is someone at high risk, but it's just as valuable to identify the patient who had lowest risk for prostate cancer, and then again, an off-ramp to avoid a prostate biopsy. So we've talked about how well does this performance characteristics of this MRI work, and essentially this is a plot looking at the sensitivity versus the specificity, and a perfect screening test would look like this rectangle box and have a very large kind of area underneath this, but you can see this curve is almost a right angle, suggesting that the performance characteristics of using this type of adoption is very well received, and we can predict with high likelihood who are going to be the men that would benefit from a biopsy and who are the men that are going to have disease that requires some type of treatment. There was a recent study that was published this year in the New England Journal of Medicine that kind of redefined actually how we had to do prostate biopsies. Historically, when we did a man's prostate biopsy, if you can imagine, this is the prostate on the right side of the screen, we would biopsy essentially 6 biopsies on the left side of the prostate, 6 biopsies on the right side of the prostate, in addition to some biopsies within the abnormal area seen on MRI to make sure we got all the potential disease. This study of just under 40,000 patients showed that we get the same cancer detection rate if we just biopsy the abnormal area of MRI and avoid all these other biopsies, which is less painful for men, less costly in terms of the medical healthcare system, and it doesn't come with any downside in terms of missing cancers. So it's not universally adopted yet, but I can see coming down the future that we can probably just biopsy a couple of biopsies into the abnormal area of the MRI rather than putting men through, 16, 18, 20 biopsies of their prostate to make sure we don't miss any disease. So perhaps paradigm changing, not quite there yet, but very thought-provoking. So with that, we'll pause briefly and discuss our next poll question. An MRI allows the physician to better assess the likelihood that a patient has prostate cancer before conducting an invasive biopsy. And it looks like everyone got that one spot on, that this risk adaptation tool has really improved the way we counsel men and help men understand if they need a biopsy, and then if they're going to have a biopsy, where specifically do we biopsy? So to switch gears a little bit, we'll next talk about those biomarkers that were endorsed by national guidelines. And there's biomarkers that can be assessed in the urine, and there's biomarkers that can be assessed in the blood. And as any good urologist, I've now labeled all the urine biomarkers in yellow and all the blood-based biomarkers in red. And you can see some of the technology is similar. You can see these microRNAs can be detected in urine as well as blood. There is some fusion genes that we see in the urine that can also be identified in the blood. So some of them overlap, but there are different ways of obtaining risk stratification. And I'll go over the 6 that are now endorsed by national screening guidelines. So this is a blood test highlighted here in red called the Prostate Health Index. It's essentially looking at different what's referred to as isoforms of the prostatic specific antigen. There's some isoforms that are associated with just an enlarged prostate, meaning no prostate cancer, just a larger prostate. And there's some isoforms that are specifically associated with prostate cancer. And this test looks specifically at those ones that are associated with cancer and avoids looking at the ones for an enlarged prostate. And it puts it into this formula. There's a 2-pro PSA divided by the free PSA times the square root of the total PSA. And I'll show you how we use this in clinical practice so you can have a better understanding. This is essentially the report card that we get if we screened a man for prostate cancer using this test. Essentially, if a gentleman comes in with a PSA of 10, which historically we would think is pretty elevated, pretty high of 10, we can see if we go through this test, the Pro2 PSA is quite low. This is quite low. Gives them a low PHI score. Ultimately, their risk of cancer is only 11%, meaning 89% chance there's no cancer there. And we would have thought historically, you know, this is pretty high, but this new risk stratification tool shows that this gentleman's pretty low risk, and they can consider whether they truly needed a biopsy if there's an 89% chance there's no cancer there. On the flip side, this is a gentleman whose PSA is 4.4, half of that compared to the gentleman we just saw. However, his Pro2 PSA number is much higher, percent free is much higher, and as a result, his PHI score is significantly elevated, puts him in this highest risk category. Now, this person has a 50% chance they're going to have prostate cancer. And really, this is informative because the PSA is half of that than the prior gentleman, but his risk is 5 times higher. So again, another risk stratification tool that we can use to inform men whether or not they need a prostate biopsy. One of the other tests that has come on the market, developed by Cleveland Clinic, is called ISO-PSA. It's again an ISO form of PSA, which you can see by these graphs. Essentially, it outperforms PSA as a screening tool, and it outperforms percent-free PSA as a screening tool for detecting high-risk prostate cancer, along with any risk prostate cancer. And this could be adapted into a risk stratification approach. The Cleveland Clinic proposes this is kind of the algorithm that they use at their institution. They screen men for their total PSA. This is a little bit old because they still have the number 4 here. We just went over guidelines that suggest it should be lower, perhaps 1. You get your ISO-PSA test. If your ISO-PSA test is normal, you don't need any further intervention. We just continue to watch you and you avoid a biopsy. If your ISO-PSA test is positive, then we can get a second reflex tool, that being the MRI. And depending on the MRI, we can determine whether or not you would need an actual biopsy. So another biomarker that we have in the tool to help risk assess men for prostate cancer. 4K score, this is another red, you can see here, blood biomarker that we can use to help assess men for prostate cancer. It comes in this nice report card form. This is an example of a man who has a 4K score of 5%, meaning they have a 5% chance they will have clinically actionable disease, meaning disease that has some type of treatment. 95% probability that will not have aggressive disease on biopsy. So that's very informative. I think that most men with a 95% chance there's no disease there, they would be willing to forego a biopsy, and we could continue to watch them so we could avoid the risks of prostate biopsy. And this 4K score was developed from a team at Memorial Sloan Kettering and is readily available for our clinical practice. This is a little bit more about that 4K score. It's essentially looking at these 4 different molecules. They put it in this proprietary algorithm, which we actually don't know what that is, but it comes out and gives us the percent risk for aggressive disease. And when I refer aggressive, essentially that's disease that requires treatment. We try to avoid diagnosing men with the disease that does not require treatment, because it just gives men a lot of anxiety that they're carrying a cancer diagnosis. It doesn't require treatment. And then there's some updated urologic literature that actually suggests the lowest risk prostate cancer maybe should no longer be called cancer per se, because it may not actually fit the definition of cancer, and it would reduce a lot of anxiety for men who have that low risk cancer diagnosis. This is one of the new urine, here shown in yellow, urine cancer risk biomarkers. And it looks for a couple of different messenger RNA genes. One is the DLX1 and the other is the HOX6 biomarker. But it gives us this nice type of report card as well. And you can see here on this top kind of report card, this is what we get when a man gives this urine sample who may be at high risk for disease. Essentially, this report card will show us the likelihood of any type of cancer on biopsy. This is an example of 85%. But what's also important is it gives us that of that 85%, 50% chance there will be high-grade disease. This is the disease that need treated. 30%, 35% of that disease will be low risk. So this is also informative in our second example. So if this is a gentleman that gives us a urine sample where we do this test, you can see likelihood of prostate cancer is now only 10%. And of that 10%, only 2% chance that this gentleman actually has high-grade disease that requires treatment. 98% chance he does not have any high-risk prostate cancer. So again, this could be informative for a gentleman to avoid an unnecessary invasive procedure. So very useful in clinical practice, and simply men just have to urinate into a cup. This is a little bit of the performance characteristics of that test. They've taken this test and they've compared it to how well that predicts cancer versus prostate-specific antigen. They compared it to another screening gene, the PCA3, and they compared it to a number of different risk calculators. And really, you can see here that this curve here outperforms all three of these other screening tools. So the advent of these biomarkers has really pushed the way forward on when we can do better screening for men with risk for prostate cancer, kind of synonymous with that smarter screening approach. This is another urine biomarker that's on the market. It's essentially for men who are 50 years or older, who've never had a prostate biopsy before, and they have an elevated PSA level somewhere between 2 and 10. They can urinate into this cup. It'll the company will run this test for us, looking at specific genes that are at risk for prostate cancer, and it'll give us a score. In this case, they use this cut point at about 15. Men with a score above 15 may probably would benefit from some type of biopsy. If you have less than 15, probably could avoid a biopsy. And you can see from this example, this is how that increased level of this test corresponds to having disease. Typically, the higher the score goes, the more likelihood you're going to have prostate cancer that requires treatment. But the vendor of this machine, or excuse me, this test says, you know what, we should use a threshold of about 15%, or sorry, a score of 15, which correlates to about a 7.5% risk assessment, meaning that most men, when questions, they would say, you know what, if I have a 92% chance of not having disease, I would forego a biopsy. Having 8% is usually about the threshold where men would consider undergoing a prostate biopsy. This is a little bit of a schematic of actually how this molecular test works. Again, it looks for a couple of PCA3 genes, the TMPRSS2 ERG fusion gene and a SAM gene. They're found in prostate cancer cells. So again, just selecting men for at higher risk for developing prostate cancer. This is another last urine biomarker that's come on the market that's endorsed by the NCCN guidelines. What's interesting about this test is it actually stratifies men even a little bit farther into those who have had a prior biopsy and those who have been biopsy naive, and they have some different thresholds. You can see here you would get a score somewhere between 0 and 100 from this urine-based test. They do suggest that at 75%, if you've never, 7.5%, if you've never had a biopsy, if your number is above this, you may want to consider getting a biopsy. If your number is below that, it's probably safe to avoid a biopsy. And if you fall into that category where you've had a prior negative biopsy, but you're elevated or your PSA continues to be elevated, this test is also useful because it gives you a different threshold. Above about 5.5, may consider a repeat biopsy. Less than 5.5, it may be safe to forego an additional biopsy in the future. So also a new urine test on the market that can be very informative to men at risk for prostate cancer. This is the fusion gene that this test actually looks for. This test was developed at the University of Michigan. I think the second version of this test is now commercially available. In full disclosure, I haven't yet adopted into my clinical practice, but I'm sure it's coming down the pipeline with more use. So one of the limitations I do want to highlight that of all these biomarkers in urine or blood, one of the drawbacks is that it can tell us the risk that a man may have prostate cancer, but what it can't do is it can't tell us where the cancer is in the prostate. And if you can see on this schematic on the right side of the screen, that without some type of guide as to where the cancer is, there is instances where we biopsy small, low-risk cancer, which we actually don't want to identify because we don't have any way to guide us. We can miss large cancers or inappropriately skive the side of them and not actually biopsy the full tumor, which may tell men they're at lower risk than they may truly actually be. Or you can see on this bottom one, there are instances where we would miss large tumors because we can't see them under ultrasound guidance. And that's really why we combine that biomarker with an MRI. The MRI allows us to do guidance in terms of risk stratification. And to kind of put this all together and to summarize, this is how I typically manage my patients in current practice. I talk to men about their risk of prostate cancer and the benefit, as well as the risks of prostate cancer screening. If men do have an elevated PSA, typically I will repeat that PSA, usually at a minimum of 6 weeks later, because there can be a number of benign, not malignant conditions that can make that PSA test abnormal. If that number is abnormal, we do discuss the role of biopsy, and typically I'll give men a prostate MRI. If men are low risk on their score, I continue to observe them. That you typically don't need a biopsy. If they're intermediate risk on that prostate MRI scoring system, we can talk about a prostate biopsy, or we can get them additional risk stratification molecular tool, one of those urine or blood-based markers we just discussed. If that is high, then go back to biopsy. If we get that secondary risk stratification and that one's low risk, we can continue to observe them. And then most commonly in those men with high risk features on the MRI, that we do recommend going straight to biopsy, because those are the men that are most likely to harbor some type of disease that would require treatment. So with that in mind, we can probably reach to one of our last follow-up questions. That is, molecular markers permit a physician to analyze a prostate biopsy to gauge the likelihood of aggressive cancer. I'll give us just a second more to answer, but I think the audience is doing very well today on all of their test questions. And this is indeed true. The molecular markers we just spoke about allow us to gauge the likelihood of aggressive cancer and therefore talk about whether men actually need a prostate biopsy or not. So some things that we still are kind of figuring out in the world of prostate cancer screening. One, that African-American men are underrepresented in most of the studies that have evaluated these prostate cancer screening tools. So there needs to be more long-term follow-up data to see how race and ethnicity impact the outcome of these tools. And it also is not clear yet how these test values may change over time. Meaning if I get a molecular test on a gentleman tomorrow, we continue to watch his PSA, it goes up 2 years from now. How is that repeat molecular test going to be? Does it change over time? We'll really need further data points to understand this. This molecular marker is only a snapshot in time. It may get higher, it may get lower over a man's lifetime. And ultimately, further research is needed to inform how these tests are going to perform. So with that, I can wrap up our presentation for today. And really our goal is now we realize we need to screen smarter for men at risk for prostate cancer. And by doing that, we can adopt secondary risk stratification tools to make this easier for men and for the provider. Those tools include both blood and urine biomarkers, as well as an MRI. And ultimately, our goal is to detect lethal disease. These are the men who would benefit from treatment, and not to detect disease that would never impact a man's longevity and therefore avoid putting him through overdiagnosis or overtreatment. So with that, I would like to thank you and then perhaps take any questions on our remaining time.
All right. Dr. Bjurlin, thank you so much. This has been fascinating. Not surprisingly, as a 61-year-old guy, I just wrote down about 20 questions, but I'm not going to monopolize this section of the talk. So we'll go ahead and our Q&A is now open. So please go ahead and use Poll Everywhere to submit your questions. And I'll start off with a couple, and then hopefully we have several members of the audience who are willing to share their questions as well. I was curious, that was interesting. There was a chart you shared early on that showed the significant drop in with lung cancer, with the change that you noted with smoking cessation. Are there any comparable sorts of changes that people can make that would be relevant to this versus lung cancer? So as we talk about prostate cancer.
Yeah, there's interesting emerging data that actually exercise has been impacting men's likelihood of developing aggressive prostate cancer or moving on to aggressive prostate cancer in men who have low-risk disease. I don't think the mechanism of how that works is yet fully understood, but I think the health benefits that come with exercise are very wide, and it's interesting that's been found that this can impact the man's risk of prostate cancer.
Gotcha. Thank you so much. So you spoke a lot about biopsies, and if we were thinking about suspected melanoma, we wouldn't think twice about getting a biopsy. And we get a biopsy, and it's a little uncomfortable for a moment, and then we go and we get the results. I'm assuming that's not the case, so there's the discomfort of the actual biopsy, and then are there other complications that can result during the biopsy?
Yeah, indeed, there can be. The prostate biopsy for men is a bit invasive. We need to put an ultrasound in a man's rectum in order to see the prostate. And then we have to put some biopsy needles in his prostate itself in order to sample the tissue. So besides being a little bit uncomfortable, that men are at risk for having an infection, they're at risk for small risk for bleeding from the biopsy itself. In some men, they can actually go into urinary retention, meaning they get some inflammation in their prostate where they can't quite empty their bladder or urinate. So there are some risks that come with the biopsy itself, and just kind of it adds to the discussion on ways that we can reduce the need for those biopsies by better screening men up front.
Gotcha. Thank you. And then we have a first question from the audience regarding exercise impact, as in lower the risk.
Yeah, so there is some provocative data that may show that you have a lower risk of developing prostate cancer. And in those men who have developed low-risk prostate cancer, if they increase their exercise, there's some provocative data that may show they have a lower risk of moving on to more aggressive disease later in their life. So both.
Great. Thank you. You talked about the germline mutations and that being a factor in all of this. Can you speak to that any further in terms of how patients would know more about what their germline related risks would be?
Yeah,
what that would be?
A lot of that may be knowing your family history. So there are some diseases that are linked to the same kind of gene mutations. For example, there are audience that may have heard of this BRCA mutation that's common in breast cancer. Then that can also be found in prostate cancer. So in men who have family histories of breast cancer, prostate cancer, colon cancer, there's this kind of triad of diseases that if they're aware of that, they may be at higher risk for developing prostate cancer prior undiagnosed.
Gotcha. And is that something that potentially would be available with something like 23andMe, or is that something a patient would need to request as part of specific testing?
Yeah, we typically do it through our kind of genetic screening program here at UNC. That is not a test for all men, but typically the 23andMe type of over-the-counter test won't capture the things that our genetics team capture. So it's a little bit more specialized test that we'd identify for certain high-risk men.
Great. And looks like we've got more questions. Good. Thank you. Right. Here's another one. Does drinking coffee reduce the risk of prostate cancer?
I don't have any solid data to suggest that increased consumption of coffee corresponds directly with lower prostate cancer risk.
All right. All right. We can wish.
Yeah.
And then is there data demonstrating a relationship between testosterone therapy or OTC testosterone supplements and risk stratification for high risk cancer?
So that's an interesting question. And just to put it in context for some of our audience members, that testosterone is typically the hormone that prostate cancer may kind of eat, for lack of a better word, to grow. So there is some school of thought that in men who already have prostate cancer and men are taking over-the-counter testosterone supplements, that they may be feeding their undiagnosed prostate cancer. But I am not aware of anyone by just simply taking the testosterone that you'll be at a higher risk for developing prostate cancer. But there is some thought that if you already have prostate cancer, this may can continue to promote its growth.
Okay, thank you very much. Just curious that I wanted to ask, since we've got another minute, what's going on in Miami? That was really striking when you showed that municipality versus the others. Do we know?
And I don't have a good explanation for that. I thought about that interestingly because in full disclosure, I'm from Minneapolis. It did very well in that kind of evaluation, and I don't have a great idea if it's just the inhabitants of those state areas that have a different risk profile based on their healthcare disparity, or if there was some type of adjustment that took into higher consideration those patients that might be more prone to disease. But yeah, I don't have a good explanation why Miami was off the charts on that study.
Gotcha. Thank you. All right. And another question, thanks to our audience for keeping these questions coming in. Is there a relationship between having a vasectomy and prostate cancer risk?
This is a wonderful informed question by one of your audience members. That this was controversial for many, many, many years because a number of large kind of data cohorts, they did some analysis that showed that there was a link between vasectomy and prostate cancer. Not actual causation, but there was some type of association that said men who were getting vasectomies were being diagnosed with prostate cancer. And I think it's bore out over the years that was just an association. There's actually no cause between getting a vasectomy and prostate cancer risk.
Gotcha. Thank you. And then last question, do we know what the screening rates are, and do we have thoughts on how we can improve those screening rates? We recently, our last SciSep lecture was specifically focused on the lung bus and screening that's going on with buses that are going out into communities throughout the state to screen for lung cancer. But are there comparable efforts or other strategies to improve screening rates?
There was a large dip when there was a change in some national policy guidelines, but those guidelines have since been reduced. So I think the rates of screening are going up. But it is challenging, especially when our primary care doctors are typically the first person to see these patients. And, primary care doctors have 20 other things to screen for. And then if prostate cancer is not on the top of the list, sometimes those get missed. But hopefully we continue to adopt this kind of appropriate risk stratification model to help detect prostate cancer at men who most need it.
Great. Dr. Bjurlin, thank you so much. I'm going to make a couple of closing remarks here. We want to thank the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center for their support. We want to thank our team members, Veneranda Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all of their hard work on each and every one of these lectures to make these possible. We